John is the director of the Africa CDC. Dr. John, good morning. Happy New Year. You have the floor.
Thank you, Wayne, and a very happy New Year to you, in particular, and the colleagues from the Africa Centers for Disease Control and Prevention. This is our first briefing for 2021, and a very happy New Year to the media that have been working with us very closely. Unfortunately, last week we couldn't meet because it was a holiday, Ethiopian holiday, and we have to respect that. So for those who celebrate the Ethiopian Christmas, I hope that it was a very well-spent Christmas in the context of the pandemic that we're dealing with. So let me, as usual, do three things. One is, first of all, give you an update on the epidemiological situation of the COVID on the continent and the world. And then I will discuss activities that Africa CDC continues to do, and then end up with the news on vaccines, where we are with vaccines. As of 9 a.m. East African time today, over 90 million people have been infected with the COVID-19 virus. And it has unfortunately caused about 1.9 million deaths across the world, and which gives a case fatality rate of about 2.2%. When you look at the continent, the African Union member states, that is all 55 of them, we have reported a total cumulative number of 3.1 million cases of COVID-19, accounting for 3.5% of the total cases reported globally. In terms of recovery, we continue to have a very stable recovery rate of about 82%. Which is, if we translate that into actual number, is 2.5 million recoveries. Unfortunately, our deaths are increasing, as I was actually saying, very rapidly, with 75,000 deaths already across the entire continent. And that gives us a case fatality rate of 2.4%, slightly above the global case fatality rate. And we'll come back to that in some details there. If you look at the five top countries that are giving us accounting for the most caseloads, they include South Africa with 1.2 million cumulative cases, and that will account for 41% of the total cases on the continent. That is followed by Morocco with 455,000 cases, or 14% of the cases. Tunisia, 168,000 cases, 5%. Egypt, 152,000 cases, and 5%. And Ethiopia, 129,000 cases, or 4%. There are several countries now on the continent that are reporting a case fatality rate that is higher than the global average of 2.2%. And if you look at the entire continent, at least 37% of the 55 countries, that is 20 countries, are reporting case fatality rates that are in excess of 2.2%. If we now look at the trends of the pandemic over the last couple of weeks, we'll look at the last week and then 4 weeks period. So this is our first epidemiological week. And that is the week between January 4th and January 10th. If you compare that with the previous week, we've recorded 222,000 new cases of COVID-19, and that represents an increase of 32% over the previous epidemiological week. And we continue to monitor these trends because, again, we have just emerged from a end of year festivity period, and where there was a lot of movement from cities to remote areas and across cities, and all kinds of different patterns of movement, and we'll continue to track the changes there. The deaths have also followed similarly. We've recorded 5,400 new deaths over the same period, that is over the period of last week, representing an increase of 21% of deaths over the previous week. The countries that are reporting the highest proportion of new cases include Southern Africa regions, 70%, followed by North Africa with 18%, West Africa 7%, East Africa 4%, and Central Africa 1%. So the 5 countries that with the highest daily new cases per million population include South Africa, Tunisia, Namibia, Lesotho, and Seychelles. So if you now look at the 4 weeks, so that was all for 1 week. If you now look at for the last 4 weeks, what are the trends? That is between December 14 and today. You observe that we've recorded an increase of 18% on the average of new cases across the continent. And by the 5 regions, the trends look like this. 13% decrease in East Africa. That's a good sign of hope. 5% increase in Central Africa. 21% increase in West Africa. 31% increase in Southern Africa, and no change in Northern Africa, so kind of stabilizing them. So I think those are the trends by region. If you now look at over the last 4 weeks, the most populous countries in Africa, because we always like to do that analysis just to see those countries like Nigeria, Ethiopia, Egypt, what the trends are. Ethiopia has recorded a 6% average decrease over the last 4 weeks, so we continue to see a downward trend. Kenya has recorded a remarkable 10% decrease over the last 4 weeks. DRC has recorded an increase of 13%. Nigeria, 25% increase. Egypt, 30% average increase. And South Africa, 30% average increase. The deaths have also followed the same pattern, where in Ethiopia, we've recorded a 3% average decrease. Kenya, 11% average decrease. Nigeria, 30% average increase. Egypt, 37% average increase. DR Congo, about 300% increase. And South Africa, 35% average increase. For more on this, please do well to visit our website. In terms of testing, we have now, as a continent, reported a cumulative number of 28 million tests conducted, and that represents about 3.6% increase over the past week. And again, the 10 countries that are reporting most of the testing, that is about 70% of the testing, include South Africa, Morocco, Ethiopia, Kenya, Nigeria, Egypt, Uganda, Cameroon, Rwanda, and Zambia. The Africa Centers for Disease Control and Prevention continues to ship test kits and other essential supplies to member states to help them meet their response need in this second wave. And in the last week, we've also started a training for mortality surveillance amongst healthcare workers in 10 districts in Uganda. So that is a program that we plan to extend across the board. So the last section of this briefing will be focused entirely on vaccines. As you probably heard yesterday, or read yesterday from the press release from the chair of the African Union, His Excellency President Cyril Ramaphosa, the continent, through the Africa Vaccine Acquisition Task Team, AVAC, has secured provisionally 270 million vaccine doses for the continent. And that's a significant achievement and very good news to start the year with. And again, this is part of our overall strategy for the continent. If you all recall, we developed a continental strategy for vaccine development and access, which was endorsed in August by the Bureau of the Head of States. That is the the group of head of states that run the affairs of the continent. And that followed a meeting that we had in June 24th, 25th, where about 3,000 participants took part in. So this is a very good outcome from the months and months of discussion. I know in this same forum, people have asked me, when are we going to have that? And my answer has been that we are working hard on it. So I'm very happy to bring the good news to you. So let me now unpack that a little bit. At least 50 million doses for this out of the 270 million will be available during the crucial period starting April through June. And that period is crucial because that is where there's really a bottleneck for vaccines, access to vaccines. The vaccines will be supplied by Pfizer, AstraZeneca through an independent license group in India, the Serum Institute of India, and Johnson & Johnson that is still to announce the results of their clinical trial. But we are in discussions with them to secure the appropriate doses there. I know the first question is, how do we finance these vaccines? So I've been saying for months that the Afri-Exim Bank the leadership is very supportive of this, and they will be the main body that will support countries in financing for this vaccine, so that members we can actually achieve our whole of Africa approach, that is leave no country behind. So the whole process will work as follows. First, after receiving firm orders from member states, which will be accessed through the platform, that is the African Medical Supply Platform, the bank will provide advanced procurement commitment guarantees of up to about $2 billion to manufacturers on behalf of the African Union members. Then upon delivery of the vaccines, countries may pay using their internal resources or access an instrumental payment facility of up to 5 years offered by the Afri-Exim Bank. There's also a close collaboration with the African Union team and the World Bank to ensure that member states are able to access about 5 billion either by buying more vaccines or paying for delivery of vaccines committed on their behalf by the Afri-Exim Bank. The AVAC acquisition COVID-19 vaccine for AU member states will complement the efforts of COVAX. So this is not to replace COVAX, but it's to supplement that. You all recall that COVAX has said they will supply the continent with about 20% of our needs. Our target, as inscribed in our strategic plan, that is the vaccine strategic plan, states that we need to vaccinate at least 60% of the population of the continent of 1.2 billion to achieve herd immunity or population immunity. So our efforts they will complement very nicely the COVAX acquisitions or mechanisms. Just to conclude that, AVAC was established in November by the President Cyril Ramaphosa in his capacity as the rotating chair of the African Union. And it has about 10 members that are working actively day and night, engaging with pharmaceutical companies, other bilaterals and multilaterals like the European Union and other countries there to continue to negotiate for access to vaccines on the continent. Thank you, and Win, let me return it back to you.
Thank you very much. That was Dr. John Nkengasong, the director of the Africa CDC. We move straight into your questions, and the first one that we are going to take is coming from Vinicius Assis from Global News TV in Brazil. And Vinicius says, what is the biggest hurdle for Africa to overcome in order to get the vaccines for all Africans as soon as possible?
So I think the biggest hurdle for vaccines in Africa has been twofold. One is the financing of the vaccines, which, as I now said, we have the Afro-Exim Bank ready to work with member states. I think that will help. And you heard the conditions. I mean, I think those are very favorable conditions to work with. And then the second thing has been the logistics of vaccinating at scale. Okay, I just want to underline that. It's not like we don't know how to vaccinate. We do vaccinations all the time, but how do we vaccinate at scale? Because if we have to achieve our 60% target, it has to be done in a way that between 2021 and 2022, we've done the vaccination, completed the vaccination of 60%. That will require a very massive historic campaign or vaccination exercise that the continent has never done before. But you require that we get organized and get ourselves actually prepared for this kind of scale up. But we are very positive that we as a continent were able to roll out drugs against antiretroviral treatment in a significant way, starting from the year 2005 going on. So we understand how to roll these things and make them work. I've said previously that let's not make this exercise academic. Let's keep it simple. There are 4 things that we must have in place to start our vaccination. The key word is to start vaccination. First is that we have to have those vaccination points starting with the major cities, which means if we are going with the Pfizer vaccine, we have the -70s or the -20s for the Moderna and create those vaccination sites. Very similar to what we do with the polling stations. When we do that, we can store the vaccines and use them and move people towards the vaccination points rather than move vaccines towards people. I think that is one. Second is that we have to engage in a large-scale training of our healthcare workers on how to deliver the vaccines. And we, Africa CDC, are developing tools, training tools that will be used, of course, in collaboration with our partners to train large number of healthcare workers that can provide this the vaccination. The third is the supplies, not supplies of vaccines, but as the auxiliaries, that is the needles that will be required, the curtains, the alcohols, and other things that are actually needed for this. So we have to have that in place. And lastly, a good information system to record people so that when we vaccinate, most of these vaccines, the early vaccines are single-dose vaccines. They are double-dose vaccines that require that you get a shot today, and then after 3 weeks or 4 weeks, you get a second shot. That will require that we get a very good system in place to track people and bring them back. And lastly, community engagement. The community will play a key role in this. We have to engage them very deliberately, formally, and make them be champions of this. So if we do those things, then we are ready to start vaccinating them. We have to keep it simple. We have to streamline it and make it practical. So those are the challenges that are required to be overcome and move this. But is it a barrier? No, I think it is. Those are challenges that can be overcome if we build the right partnerships and we bring the right political leadership there, especially now that we have the vaccines on our platform. This is a time for our member states to accelerate their preparedness effort.
Thank you very much, John. Let's move on to Paul Carsten. And Paul is with Reuters News in Nigeria. And he has 2 questions. The first one, yesterday, President Cyril Ramaphosa announced that AVAT has secured 270 million COVID-19 vaccine doses for African countries. The question is, how will you decide how those 270 million doses will be divided between the 2 countries? And the second part of that first question, how much will South Africa get out of that 270 million? Then he goes on to the second question, will African countries be avoiding vaccines requiring ultra-cold storage due to the need for additional infrastructure? And if so, could you explain some of the thinking behind that? And which vaccines will you be prioritizing instead? Those are the questions from Paul.
Yeah, so Paul, I was just writing the series of questions from Paul so that I try to address them all. So how would the vaccines be divided? I indicated earlier in my briefing that we will use the same approach that was used through the African Medical Supply Platform, where, if you recall, when we had a shortage of diagnostics, and we started bringing in diagnostic into the platform, there was a formula that was used there, and the allocations were indicated there. And this will be done totally transparently, based on the population size, based on the pandemic, the epidemiology of the infection in the countries there. But for the ease of, the sake of and interest of time, I would say, if anyone is interested, you go to the platform in the coming days, and you'll be able to, it's amsp.africa, and you will be able to see, the different allocations by the countries there. I don't have, the numbers per country for 55 countries offhand, but again, I'm also ready to send it to you by email if need be. So it was all presented yesterday to the Bureau of the Head of States. I think that is all public information now. That is what we'll make available on the platform in a very transparent and open manner, using clear formulas. Countries that will not be willing to take the allocations will, of course, move the allocations. We'll give them a time to commit, and if that time elapses, we'll move those allocations to countries that will be in huge demand. Remember that 270 million doses is definitely not enough for the continent to enable us get to 60%, but it's a good place to start, because we know that the pipeline for vaccines is very promising. And we are still waiting for the Johnson & Johnson vaccine. We are still reviewing the data from the Russian vaccines and others. So the pipeline is, the critical period is, as I said, is how do we get started? So I think that is, so in short, I cannot be able to give you details of country to country, including South Africa, because I don't have the numbers offhand, but you can get that. Either you send me an email after this, or you go to the platform in the coming days. I'm not sure if the platform has uploaded that information, but in the coming days, you should have that. Let me address the issue of ultra chain. I think I take an exception that the so-called ultra chain is a problem. It is not, a problem. I've just described the way we will approach it. We are not recommending that countries go out there and buy -70 or -20 degrees deep freezers and distribute them across the entire countries. No, that's not our recommendation. Our recommendation is that there are only 2 vaccines out of the 3 vaccines or 4 vaccines that require that ultra chain. That is the Moderna and the Pfizer. So let's keep the Moderna vaccine aside, because it's a vaccine that has been embargoed to be used in the US. So the Pfizer vaccine is the one we are expecting. How would I approach that? So if I take a country of Ethiopia that I'm resident in, I will be advising the government and say, look, you start with the major cities. You put in -70 degrees Celsius the deep freezers at what you call vaccination points, and this will be the hospitals. And each of these deep freezer will cost about $10,000 to $15,000, depending on which one you buy. Besides that, you get a backup generator, which will cost about $15,000, just to be sure that power is steady there. So you're out of the 5 things are listed, you tick the box. Okay. Then your community drive engagement follows, where you engage the community and push them and drive them and point them to where those vaccination points are. So here you are not. So a city like Addis Ababa, if you put 20 vaccination points there, you're good to go to get started. And you learn from that experience and you scale up. There will be mistakes made, and there will be lessons learned, and you scale that up there. So again, I'm totally not of that view of that the cold chain, the ultra cold chain. It's a narrative that inhibits preparedness. It's a narrative that doesn't make us get ready, because we get inhibited in our thinking there. But we should simplify it and not make this an academic exercise at all. We as a continent is ready to go. If you tell us that the vaccines are coming today, we'll be advising countries accordingly on exactly what to do based on those 5 things I just listed. The last question was which vaccines? I just listed the vaccines on the AVAC platform. That will be The Pfizer vaccine is on the platform. The AstraZeneca vaccine will be on the platform. The Johnson & Johnson, we are hoping that it will produce the intended results, and then by the period of June or so, we'll begin to get the doses there. And the AstraZeneca vaccine, remember, doesn't require ultra cold chain facilities, just as the Johnson & Johnson vaccine would also not require that. It will be a single dose vaccine and require that you use the regular cold chain, which is the 2 degrees or to 8 degrees there. So again, I really plead that we do not let this concept of ultra, like as if all vaccines for COVID will require minus 20 or minus 70 degrees. If you put in minus 70 degrees Celsius deep freezers in a city like Addis, and then 5 months down the road, you get a different vaccine that doesn't require, can you use it? Yes, of course. You take those to different hospital settings or laboratories, and they'll be able to use those deep freezers for other purposes there. So that's the way I will address that question.
All right, we didn't lose full audio, but we seem to have lost the audio between the two there. So we will keep a close eye on that, a close ear on that. And as soon as that begins again, or as soon as we gain that audio back, we'll take you straight back there. The Africa CDC briefing giving us critical updates on the COVID-19 response activities and progress made towards implementing the joint continental strategy for COVID-19 response in Africa. The latest numbers, as you heard it there, over 3 million cases have been reported. We have just heard that the fatalities are increasing rapidly. About 75,000 people have lost their lives so far. The recovery rate is sitting at about 82%. So that's the latest with regards to the situation on the continent. We have the audio back. Let's take you back there now live.
So we have two people who are actually raising their hands to ask a question. First of all, I'll call on Paul Adepoju to ask his question.
Yeah, thank you very much and for the opportunity, and happy New Year to Dr. John. This is Paul Adepoju from The Lancet. My first question is on logistics. With April not far away, what has been specifically done by any African country in readiness for COVID-19 vaccination? We like examples of what African countries have been doing. The second question is, there has been calls for companies to free up the vaccine intellectual properties. And has any progress been made in securing licensing such that African companies that have vaccine production capability would be able to locally produce it. While the third question is something you said you will mention, but you didn't mention, which is Africa now has a slightly higher case fatality rate than the rest of the world. So what is responsible for this, and what does it mean for the pandemic on the continent? Thank you.
Thank you, Paul. Those are very good questions. I think for the case fatality rate, remember I said there were, let me just go back to the notes. I said there were 20 countries that, or 37% of our member states that are reporting more than 2% case fatality rate. And that number is increasing. If you recall, previously it was, we were under that number. And our case fatality rate used to be like 2.2%, whereas the global case fatality rate was 2.4%. Now you are beginning to see the reverse of that, where the case fatality rate for the world is 2.4%, and then our case fatality rate is around 2. So for the world is 2.2%, and our case fatality rate is 2.4%. So what is accounting for that? As you get more people infected, especially during this second wave, you expect more hospitalization to happen, and because of inadequate health systems to support that, you expect that mortality will increase, and especially with oxygen. I think I'm happy you raised that question, because one of the strategy that we'll be adjusting in to fight the second wave is that we really want countries to have a sufficient oxygen supply, because basic oxygen availability can actually make a big difference and decrease our mortality rate across the continent. With respect to your second question on the vaccine IP, discussions are going on. And you know that South Africa, and a few other countries are driving that charge. A few other countries outside of Africa are driving that call for action for IP, intellectual property, to be made available for manufacturing. That will be key and to ease access. And very importantly, so in terms of if it happens, it so happens that vaccination will be a multi-year approach, like the influenza vaccine, then you really require that to meet our continental needs. But discussions are still ongoing, and we have not finalized. I just didn't quite capture the first question, so if you don't mind repeating that, I will appreciate that.
So thank you. The first question has to do with what has been done by individual African countries specifically in preparation for this COVID-19 vaccination. Has any country that you know procured any of these deep freezers in lens centers? So we need specific examples of what has already been done by any African country in preparation for the vaccination exercise.
So, first of all, guidance have been produced by the Geneva Group, the COVAX facility, as to what to do. And we have also developed guidance with respect to how to do it. Okay, the Africa CDC. So you move from the what to do and how to do it. That is all done. Those are the second thing is that individual countries are not just waiting. They are preparing. I take Nigeria for example. I think there's all kinds of innovation, especially using solar power to see how they can maintain this minus 20s or minus 70 deep freezers there. So I have no doubt that countries are really preparing this seriously, and we will be accelerating with countries the training of healthcare workers. If you remember my 5 points, one of those in 5 points for preparedness is we have to train healthcare workers in large amounts so that they can actually roll this out with speed, because speed is of essence now. What comes to mind, Paul, is really a quote that Dr. Martin Luther King used in 1963, where he talked of the fierce urgency of now. We cannot wait. This is not a polio or measles vaccination. We have to do it quick. Our economies are down. People are dying. We have to really borrow from that call to action, or that phrase that Dr. Martin Luther King used in 1963 of the fierce urgency of now. now. Tomorrow has to be today. It is a call to all member states to really put into play their systems. And now that the vaccines are there, they can access that through the platform we indicated. There's absolutely no reason for accelerated preparations not to occur, especially also given that the World Bank is talking to countries and making available resources to be used for vaccination and not just procurement of vaccines. So the opportunities are out there for this accelerated preparedness to occur. It shouldn't be a complex exercise at all. I think if you remove the whole thinking of a coach, ultra coaching, which I don't think I subscribe to that, then it becomes a logistic arrangement that is very, very within reach of our capabilities as a continent. James disappeared too.
James just unmuted me, so can I go ahead with the question?
Yes, please go ahead. Sarah, go ahead.
Thank you so much. So the Africa CDC is advocating for countries to use their special drawing rights to help fund vaccine rollouts. I'm hoping to get clarity on the $1.8 billion figure. Is this an estimate of existing SDRs available to African nations left over from the 2009 financial crisis, or does that $1.8 billion include SDRs that would be donated by countries outside of Africa? Is there a total figure on how much in existing SDRs are available to African nations without donations? And could you provide more insight on what will happen with the leveraging process at the Africa Exim Bank? Will they leverage an additional $5 billion in funds to create $6.8 billion, or does the $5 billion include the $1.8 billion? And will the leverage funds be available to countries in some sort of concessional lending facility? And will a new facility be created? And just to confirm that this is all separate from the commitment guarantees to manufacturers that the Africa Exim Bank is providing? Thank you.
Yeah, I think let me tell you what I know. I think the ceiling of up to, we call it ceiling, or the amount of up to $5 billion is what I understand from financial people. I'm not a finance expert. I work with these finance experts. Then is what the bank is ready to raise capital up to that amount, and the AU is going to be working very as a collective. To submit a decision at the upcoming Executive Council meeting, so that and also to the head of state level at the February sitting, where the decision will be taken that will make sure that the African countries work together to raise that amount, to enable the Afro-Exim Bank to raise that up to that amount of money. With respect to the special drawing rights, the 1.8, I think that is what was put forward, but I cannot for sure tell you how the progress that has been made with respect to achieving or acquiring the special or tapping into the special drawing rights for member states. I wish that my other colleagues that are part of the AVAC, Benedict Orama, the president of the Afro-Exim Bank, or Dr. Donna Kaburuka, those are the experts in the technical working group that are dealing with finance. I mean, my role is to tell them what we need, and why we need it from a public health standpoint. Their role is to find the money to make me get to my targets there. So I can certainly find those questions, Sarah. If you send me an email, I'll send it to them, and they'll be able to respond, and even directly to the Benedict Orama, and you. I'm sure you'll be very happy to provide more details on that.
Thank you very much, John, and my apologies for the slight technical problem that we had earlier on. Colleagues, now we move on, and let's hear from Jenny Ravello, and Jenny is with Devex. She has two questions. The first one, there has been an increase in COVID deaths in the WHO Africa region. What is contributing to this, and is there are there any particular countries of concern? So that's one. The second one, what is being done to curb this increase in mortality from COVID-19 in the African region? And are there concerns that delays in vaccine rollout in the region may have an impact on the death rate? So those are the two questions coming from Jenny Ravello.
So would delay in vaccine cause increase in death rates? I'll reverse the question and ask you rather that of course, any early introduction of vaccines will help the situation, not just in Africa, but across the world. I think that is a simple fact. So we are really hoping that we, with this effort, together with those from COVID, that vaccination will start as soon as possible. Now, we have to be very careful that vaccine itself is not seen like a magic bullet of this. I mean, vaccines will definitely be a game changer, but it will be a game changer over the next couple of months and not weeks. Because even if someone is immunized today, as you know, it will take you another 3 weeks to 4 weeks to get a second shot, and then the vaccine kick in, the work, and then, of course, we prevent the infection or disease. So clearly, any early introduction of vaccines will help with prevent infection and, of course, prevent deaths. With respect to mortality, they are increasing, and there are a series of countries that we have here which have recorded a case or are recording a case fatality rate of more than the global normal. Sudan, for example, is recording a case fatality rate of 6%. Egypt 5.5%, Liberia 4.5%, Mali 3.9%, DR Congo 3.1%. I'm skipping here. South Africa 2.8%, Sierra Leone 2.7%. So about 20 countries in that are really having their case fatality rate that are greater than the normal. What is causing this? As I explained earlier, we know more about this virus than we did 1 year ago. We know more how to manage the virus than we did. The increase in number of cases means that, of course, you always run into short supplies of oxygen, primary oxygen. I think that is very, very important. We know there is no treatment for COVID-19. I think we have Dexa is out there, which has been shown to be effective in severe cases by reducing mortality of about 25%. That is dexamethasone. And Remdesivir was out there, but we now know from WHO studies that is, so we're really counting on case management of this, supply of oxygen. And again, that's also another challenge for the continent. Oxygen supply is not widely available as it should be, and we will continue to work with our partners. I think there's actually a meeting tomorrow that I will be participating with the WHO and other partners to really think through how do we increase our supply for oxygen. I think that is key. The case management using basics and essential stuff like availability of oxygen is very critical to reduce mortality.
Thank you very much. Let's say good morning to Coletta Wanjohi. Coletta, good morning.
Good morning, Wayne. Can you hear me?
We can hear you.
Please go ahead.
Great. Happy New Year, Doctor and Wayne. on the issue of vaccines, if we get at least 50 million doses by April, June, what guarantee do we have that we shall have consistency of vaccination? Because there is, I think, speculation, or people are a bit scared that once we start vaccinating maybe by June, then there might be a lapse if we don't get a supply of vaccines, and we might not be able to really get to the target that we want. Then secondly, Doctor, what more do we know about the new strain that we are seeing in South Africa and reportedly in Nigeria? Is there a possibility that other countries still have the strain, but because of their low health facilities, they cannot detect it? What more do we know? Thank you.
I think that once we start vaccinating, trust me, Coletta, we will not have disruption in that. I think we are optimistic that the pipeline for vaccines will ease with time, over time, and based on other arrangements that we are doing, which of course is too premature to be discussing it now. We have both bilateral and multilateral that they will have a consistency in the supply of vaccines. I think I'm not so concerned with that. I'm concerned with getting started and using a stepwise process and in a phased manner, which means we start with our healthcare workers and vulnerable and start vaccinating those as soon as possible, learn from that experience, and as we roll that out and as more vaccines become available, we open that into the reality of our own continent. I think that is clear, that we need to also factor the fact that 80% of our economy is informal, and say, okay, how do we expand these vaccines to the informal sector, like the young people that are out there hustling to earn $1 or $2 a day, and with all the motorbikes, the bus drivers, and others. So that's where the community engagement component is so important, so that the vaccines become available, and there's also willingness to uptake those vaccines. With respect to the variant, I think there is clarity in public health. We say that if you test, you find it. Well, what is happening in South Africa is not unique. I would argue, as a virologist, the only difference in South Africa is that they are sequencing a lot. They are looking at the genetic and makeup of the virus through sequencing extensively. I would also theorize that if you do that in other countries, you will find those variants. This virus tends to be transmitted quickly and spreads very, very quickly. So we have also seen some reports from Zambia and I think Botswana that these variants are there. So it is. I will submit that as a hypothesis that if you sequence for more African countries, you see this variant. But let's put this variant in context. Okay, that is the same methods that we know that work for prevention of the virus of COVID-19 will work for this variant. So this is not a new virus. It's a species, it's a unit, or I'll call it, or a species of this entire virus. So if we wear a mask correctly, we wash hands, we sanitize, and we stay away from, we maintain social distancing, avoid mass gathering, you still prevent the virus and prevent the variant as a whole. People, when I see countries saying, well, we put restrictions on travel to this country or that, I say, well, that doesn't help the situation. What we should be doing is reinforcing that we do a test and have a negative COVID test to travel. So if your test is negative, it means you are negative for everything, including the variant. So we have all evidence that this variant is being picked up by the current test. So it's not like if you're infected with a variant, you have a negative, a false negative test. So I think we should really continue to apply ourselves to the same measures that we've applied for the last 10 months, but at the same time, continue to conduct research that will teach us what this variant really means in terms of clinical outcomes. Yes, it's making people sick and going to the hospital. That means they overwhelm the hospital system, but we do not yet have evidence that is making people die more than the other, the non-501 variants there. So I think that's the way I will look at that. And lastly, perhaps is the whole concept of would that be effective with current vaccines? The indications that it will be the current vaccines will be effective, but again, you have to understand that, and I have to speak like a virologist, that we know a lot about this virus. We also don't know a lot about the virus because it's a new virus. So only research will tell, especially when we start expanding vaccination on the continent, we'll know if these variants actually have an effect on the effectiveness of vaccines.
Thank you, John. Talking about variants, we have another question coming from Kara Anna. And Kara is with AP. And she says, has another variant of the coronavirus been found in Kenya? And what is known about it so far? And how widespread is it?
So I have not, to be quite honest, seen the report from Kenya on the variant. The Kenyan variant. I will not be surprised that there are many lineages there. And there are many variants out there for sure. I would not be surprised that another variant has been detected in Kenya. As I said, remember what I said. If you sequence viruses, you find more diversity of either the subtypes or the genotypes or the variants. So it will not be surprising. I don't want anyone to leave our conversation with the fact that, this virus is changing so much. I mean, this is known for RNA viruses. The RNA viruses tend to commit a lot of errors in multiplying themselves. And of course, that is the way for them to survive. And most of the time, because they multiply and they commit errors, they die off. But a lot of the time also, because they produce new species or variants that become more infectious over time. So it's a balance. I mean, the virus is trying to survive based on the pressure that the immune system is exerting on it. We expect to see this over and over again. But it's not like the measures that we have in place are not effective against these new variants or new genotypes.
Thank you for that. We have questions coming from Peter Mwai, and Peter is with the BBC, and he has two questions. The first one is, how many countries so far are administering vaccines? And is it possible to say which vaccines those are? Then the second question from Peter, we have seen some concern about why South Africa, the worst affected country on the continent, is yet to receive vaccines, despite the country being one of the most advanced economies in Africa. What would you say is the reason behind that? So those are the two questions coming from Peter Mwai of the BBC.
So, Peter, very good questions. I think from what we know, and we, Africa CDC, have just established what we call surveillance for vaccine use on the continent, so that we understand how these vaccines are being distributed. To just completely admit, I mean, in as much as we, as the African Union, Africa CDC, are preaching for the whole of Africa approach, and they need to work collectively. Countries are sovereign states. They are engaging bilaterally, and of course, they are doing their own things. We are encouraging them to come into the fold, that there's strength in unity, and we need to work together so that no country is left behind. We know that Egypt and Morocco have been working with to get the Chinese vaccine out there. I mean, I don't know if large-scale vaccination has started. Yesterday at the bureau meeting, the Minister of Health of Egypt offered that we should engage, and we will be engaging. We have actually sent a note verbal to Egypt and Morocco to understand more what vaccines there. But is that the Chinese, the Sanofi vaccine is what they are working on. We also know that I believe Seychelles is also working with the Chinese to use the vaccines. So as far as I know, those are the vaccines that the countries in Africa that are doing some types of vaccination. Guinea, also Conakry, has is working with the Russian vaccine, but we don't know yet if it is vaccination or clinical trials. Okay, we are looking into that and engaging the country to share more information on that. South Africa, again, is not, despite the worth of South Africa, it's not necessarily whether you have the money or not, it's whether you have the vaccine allocations. I think South Africa, you heard from the president of South Africa just earlier this week, I believe, that he made an announcement in his televised speech that South Africa has acquired about 20 million doses of vaccines. I think South Africa is getting there as the continent is shaping to get there. So it's a collective question of access and availability of vaccines, and also the question of financing of the vaccines.
Thank you very much, Dr. John. We have a question from Elizabeth Merab, and she says there is an ongoing debate around vaccine dosing. Will the Africa CDC advise for single dose or 2 doses?
No, we Africa CDC take an exception in that debate. It shouldn't even be a debate. When a vaccine is licensed, it is licensed based on how it was the clinical trial was done, right? So for the AstraZeneca vaccine, for the Pfizer vaccine, Moderna vaccine, we know exactly how they were done. There was a 2-dose dosing vaccine, which is the prime and the boost, and it's based on those conditions that those vaccines were provisionally licensed. Okay, provisionally here is very, very important because an emergency use authorization was issued. Now, if we take that and then we say, well, instead of doing it with as it was conceived for the clinical trials, remember there are 2 factors, key major factors that you look into vaccines. One is it safe? And second is it efficacious? If you start deviating from those parameters, then again we get it becomes a very slippery slope that we Africa CDC would not like to go down that slope. So our position is clear. If a vaccine was tested for safety and also tested in phase 3 clinical trials as a double dose, it should be used as a double dose. The Johnson & Johnson vaccine is coming up as a single dose. We keep our fingers crossed that the vaccine will show efficacy, a good efficacy results, and then it will be the emergency use authorization will be based on a single dose, and at that point, of course, it will be used as a single dose. So I think our position there is very, very clear on this, the use of vaccines. And just to add that, we have established now a task force on the continent of regulatory agencies that have come together, as a matter of fact, just 2 days ago, to establish themselves as a collective of regulatory bodies so that we can work regionally using the same and standardized approach from the African CDC to facilitate the approval process and regulatory processes of vaccines. So that if a vaccine is submitted, say in South Africa, they work with the SADC regulatory authorities there and put their stamp of approval there to facilitate uptake in the region. So I think, and they'll be looking into those considerations. What you just indicated was the vaccine, the emergency authorization use issued based on single dose or on double dose.
All right, thank you for that. Let's move on to Sophie Mukwena. And Sophie is the SABC News Foreign Desk Editor. And she has 2 questions. The first one, can you unpack your observations on testing and the surging numbers in South Africa? That's one. The second one, is Africa looking at building its capacity on manufacturing of drugs in general, and particularly the COVID-19 vaccines? And also, when is Strive Masiyiwa going to brief the media on the work that he is doing as requested by the African Union? Those are the 2 questions coming to you from Sophie Mukwena.
So, Sophie, those are 3 very good questions. And I think now that the chair of the union, President Ramaphosa, has issued a statement on the work of AVAC, I'm sure that AVAC, as a collective, can actually organize a press conference, and I'll take that as a suggestion. I don't know that Strive Masiwa, who is part of the AVAC, I'm also part of that, as well as president of the Afro-Exim Bank, Urama, if he was planning to do that. But I think I will take that recommendation back to the AVAC group, that they need to have a briefing on that. I think that is clear. With respect to when Africa could manufacture, I think there are three things that guarantee the health security of a people. One is, can you manufacture your drugs? Second, can you manufacture vaccines? And third, can you manufacture diagnostics? And we've captured all of these things and issued what we call the post-COVID a new public health order for Africa, which we've submitted as a report to the leadership of the continent in view of the upcoming summit, so that the head of states can look at that and say, this is what Africa CDC is recommending as part of preparing the continent, so that we begin to liberate ourselves from this discussion of, we don't have the diagnostics. We are waiting for a country X to give us diagnostics, which we could produce that locally. So it's all captured in that concept paper, the position paper that we've produced there. So we are calling it a new public health order in three different areas. One is the ability for the continent. We are saying the leadership should really push and commit themselves to what you just said, research into drugs, vaccines, and diagnostics. And you can, from this pandemic, you'll be glad to know that at least 5 countries are now in a position to produce diagnostics. At the start of last year, none of them was doing this. And I think that is very encouraging. We would like to see this expand in the areas of vaccines and drugs as well. So that is one. The second area that we are advocating as part of a new public health order to ensure the health security of our continent is the area of workforce development. We currently are in need of 6,000 epidemiologists. We only have 1,900 epidemiologists on the continent of 1.2 billion people. So there's a gap right there of about 4,000 epidemiologists, just epidemiologists alone, not to talk of laboratory experts and others there. So again, in the spirit of a new public health order to prepare the continent, we need to invest in that area. And thirdly and lastly is that we are saying that you need a strengthened and empowered Africa CDC. But then you also need each country to have their own national public health institute, similar to what South Africa has, the National Institute of Communicable Diseases, the Nigeria CDCs, the Ethiopian Institute of Public Health, so that we can form a network and work together with the regional collaborating centers in Africa and the Africa CDC to ensure an architecture that can guarantee the health security of our continent. So I think those are 3 major things that we are proposing to the leadership of the summit in May. I think your last question on the testing in South Africa, to be quite honest with you, I have not personally looked at the data in South Africa detailedly and look at the testing numbers and the case positivity rates and match them and compare them over time. I have not invested into that, but it's something that we need to look into very, very carefully and continue to encourage countries to scale up testing as much as possible so that we can actually know the caseloads and develop the appropriate strategies.
Thank you for that. Let's go back to Paul Adepoju from The Lancet. And Paul says, as Africans travel from one country to the other, they incur testing costs. And there are also reports that fake COVID test results can be obtained in some African countries. What is being done to ensure easy, affordable, or probably free testing for travelers?
So let me just put this in context that the testing the cost of testing for traveling is not only an issue for Africa; it's an issue across the board. I'll tell you this: I was in the UK just over the holidays, and I was very surprised, and actually say I was shocked when I called a testing facility to do my COVID test, and they said it was going to be about £175. And I asked the person on the other side if that number was right, and I converted that into dollars. It was like $200 or so. So, and I was a family of 3 traveling there, and it was really like, okay, yeah, this is really so. The cost of COVID testing for travel is really not just an African issue; it's a general issue there. So, on the continent, you all recall that we anticipated this a long time ago and launched what we call the Africa CDC Trusted Travel. I will ask that you go to our website and look at the africacdc.org/trusted travel, and you see a lot on what we are trying to do to harmonize travel across the continent. I think countries are beginning to implement that. Kenya, you recall, just issued a statement this week that they're all using the trusted travel, which begins to address the issue of the fake or reliable laboratories. That if you go in there, you can actually know which lab the results came from, and in a verifiable manner. And I think that is something that we are actually encouraging all member states to use that platform as much as possible to decrease the need for to worry about fake results. We knew early on that that people are people, that you can't control human behavior, but we need to put in safety nets to ensure that the COVID tests that we use around to travel across the continent are actually valid and credible. So again, please visit the website to read more about that, or otherwise send me an email. We'll be happy to send you a lot of material on what we've done to address that area.
We have a quick question from Neil Munshi of the Financial Times, and he says, how severe is the current second wave of the pandemic in Africa, and what is driving it?
It is very severe, I would say. I think we know that what we are seeing in the world and in Africa with respect to the second wave, and who knows, potentially the third wave, is very common with pandemics, and then the coming waves, and I think what is driving it, of course, is clearly that is human behavior. I mean, period. I mean, what is? If we so we are not very we are not desperate. We know what works, right? If you look at Kenya, Kenya has gone through the first wave and the second wave, and as I indicated today, it is coming down steadily. I mean, it means they are doing the right things. I mean, and they don't have vaccines yet. It means what is working in Kenya is actually public health measures. I mean, restriction of movement of people, targeted lockdowns with the use of course, public health measures, avoiding gatherings, masking, and others there. So, but if you see the continent as a whole, we started off very, very well last year, where there was a lot of masking. People were masking and social distancing. But as you walk across the continent, I mean, and all of us do, I mean, you see that there's really what I call prevention fatigue has set in, and masking has decreased, which is unfortunate. It is an appeal that I issued to the leadership of the continent that they should subsidize masks so that people should continue to wear the mask. Masks for now are our best vaccines that we have. Okay, they work. So I think we should not neglect that component there. Now, with respect to the severity of the second wave, at the peak of the first wave, we were recording 18,000 cases per day around July, August of 2020. Today, as we speak, we are recording about 30,000 cases per day. Okay, and we are not yet at the peak. We have to still wait and see what will happen, given what the movement of people was over the holiday seasons at the end of the year. I think that is very, very important that we'll continue to track that. So, but again, the way we are today, we have actually exceeded twofold where the peak was of this pandemic in July and August of last year.
Thank you, John. Now we move on to our last question, and this one is coming from Della Russell, and she is with the Daily Graphic in Ghana. Can Dr. John provide more clarity on the intended coordination program among the national regulatory bodies of member states that he made mention of?
So the take-home message is that we want to have a coordinated and harmonized approach, a coordinated, standardized, and harmonized approach for regulations of vaccines on the continent. Let's be very practical. So if the Pfizer vaccine has already gone through the FDA approval process and has also gone through the WHO, call it emergency authorization use, should we be doing it in countries one by one, that is country by country? I think, in my view, given the emergency and the urgent nature of what I said, the fierce urgency of now, is that we should not. We should do that as a group. So, for example, if the vaccine is going to East Africa, the East African community should bring in their regulators together, and then they work together and share the information, look at the dossier, and issue their stamp of approval that will enable the entire region to use it. I'm using East Africa just as an example. So that is what that process is. That way we're all talking to each other, coordinating, using a set of guidance, which we have issued. I mean, the meeting a few days ago, we issued a guidance to this, and a communique will be issued, and you see details from the communique together with the guidance that we are producing and the procedure, different categories of options that countries have there. So that's what I can say at this point, but I would say that feel free to reach out to me. We'll be happy to share with you the guidance document as well as the communique, which should be out today or tomorrow.
Thank you very much, Dr. John. That was our last question for today. Can I just ask you, as usual, to give us your summary of the main headline points that you want our colleagues to take home?
So thank you, Winnie. I really like to make an appeal to member states that there is really that fierce urgency of now to intensify and increase preparedness for vaccines. Roll out on the continent, especially now with that we know some timelines as to when the vaccines may be available, where in the coming days you can start get into the platform and order the vaccines. So that is one. My appeal is really borrowing from Martin Luther King's fierce urgency of now. The second is really that countries should now take on this. The ball is in the camp of the countries to engage and start placing their orders. Okay, so that we can actually know the volumes that have been pre-ordered, and then the Afro-Exim can engage with this, the manufacturers, and do the payments. I think you have to express and manifest that interest of getting the vaccine through the platform. Very clear. In the coming days, we will be intensifying this call to action by sending out note verbals to member states with clarity of some of the information that I just discussed here. My third and last message is that we should not, again, see vaccine as the magic bullet for now. It will take time for vaccines to actually be rolled out in a way that will have herd immunity or population immunity. So the tools that we have now is the public health measures. I'll borrow from President Ramaphosa's speech the other day, where he talked of avoid close contacts, avoid close fora, avoid being in closed rooms where people are gathered a lot there. So again, we know that it works. We are not helpless in this second wave. We know that there are some good examples. There are at least 8 countries on the continent that continue to see a decrease, including Ethiopia, Kenya. So it means they are doing something right. So let's continue to scale up those public health measures. We need the public. It is also my call to the public that this pandemic is severe. The second wave is more severe than the first. We all just heard this week that, unfortunately, our death rates are increasing. But at a more country level, I extend my sincere sympathy to the leadership of the government of Malawi, the president of that country, for the 2 cabinet ministers that died just 2 days ago because of COVID. So it is extremely unfortunate, not just because of the 2 ministers, but of the above about 75,000 people that have died and close to 2 million people that have died in the world. But again, it is hitting hard. The second wave is hitting very, very hard at the continent there. So the community and the population needs to continue to cooperate, and by avoiding mass gathering, wearing of masks constantly, and making sure that we maintain the hand hygiene. If we do that, we'll continue to bring down to fight the pandemic while waiting for vaccines to be available, which we hope come April, May, we'll really start an expanded program on vaccination across the continent. Thank you.
Thank you so much. We thank you, Dr. John, as usual, for being on this platform every single Thursday to COVID-19. And colleagues, journalists who were with us, let me apologize again.
Live visuals of the Africa CDC briefing. Look, the novel coronavirus disease has now spread to about 220 countries and territories with more than 90 million cases, and claimed over 1.9 million lives globally. In Africa, as you heard, over 3 million cases have been reported in all countries, with nearly, about 75,000 fatalities. The Africa CDC briefing, they're giving us this critical updates on the COVID-19 response activities and progress made towards implementing the joint Continental strategy for COVID-19 response in Africa. So the latest numbers, just to wrap up for you, over 3 million cases have been reported, and we've just heard about these fatalities that are increasing rapidly. About 75,000 people have lost their lives. The recovery rate is sitting at about 82%. The top 5 countries, we have a graphic. I just want to put it up for you, give you a sense of what we're talking about here. Top 5 countries on the continent with regards to COVID-19 cases. There you see South Africa leading with over 1.2 million and over 35,000. Then you have Morocco, over 445,000 cases reported and over 7,000 fatalities. Tunisia follows. Tunisia is sitting at 168,000, over 168,000 and over 5,000 fatalities. Then Egypt and then Ethiopia. Egypt at 152,000 with over 8,000 fatalities. Ethiopia recording 2,000 fatalities with 129,455 cases reported so far. So that's the situation with regards to the continent. You heard about the vaccine developments as well. We'll have much more in our later bulletins. With regards to our breaking news,